Good evening, ladies and gentlemen. I welcome you to this live dental webinar. It's a pleasure to have you as our dear participants for a very interesting webinar on the topic peri-implantitis, growing problem in dentistry. We hope you all have been doing well and are keeping safe. We hope most of y'all by now have resumed back to your beloved dental practice. If you have, then I quickly want you to comment your full name and the city where you reside and whether you have started with your dental practice. Let's keep a short introductory session on this beautiful evening. You can type down your full names, the city where you reside, and whether you have started with your dental practice. You can comment the same in the chat box below. Thank you to everyone who's joined us for this very interesting webinar. It's my privilege and an honor to welcome our dear speaker, Dr. Walid Al-Taib. Dr. Al-Taib received his dental degree from the Faculty of Dentistry, Damascus University in the year 1998. He completed his Masters of Science in Periodontics in the year 2004 and went on to pursue his PhD in Periodontics in the year 2007. He's a certified master from the Academy of Laser Dentistry, Florida, United States of America. He is in the board of directors of the Academy of Laser Dentistry and an ALD Speakers Bureau. He's participated in numerous conferences in Middle East and the USA as a speaker in the fields of periodontal medicine and laser dentistry. He is running Pink Aesthetics and Laser Dentistry courses with the British Academy of Implant and Restorative Dentistry in Qatar, Bahrain, Saudi Arabia, Oman, and the United Arab Emirates. Dr. Al-Taib achieved an advanced level of knowledge about the applications of lasers in dental science and patient treatment with Advanced Proficiency Certificate of Academy of Laser Dentistry. He is a lecturer in the Catholic University of Rome in Italy. Dr. Al-Taib received the John G. Sulewski Distinguished Service Award. He is the founder and chair of ALD Gulf Laser Chapter. He is a chair of the Academy of Laser Dentistry International Relations Committee. Dr. Al-Taib is the founder of Laser Section in the British Academy of Implant and Restorative Dentistry and the founder of the Professional Diploma in Advanced Laser Dentistry. He is a General Secretary of ILED 2018 and ILED 2019 conferences. Dr. Al-Taib is working in private as a periodontist and implantologist in Tamim Dental Polyclinic in Doha, Qatar, Dr. Imran Aesthetic Care Center, Dubai, UAE, Masters Dental and Aesthetic Center, Abu Dhabi, UAE. It's a pleasure to have a speaker, Dr. Walid Al-Taib. Ladies and gentlemen, over to our speaker on the topic peri-implantitis, growing problems in dentistry. Thank you.
Thank you, Robin. Thank you for a nice invitation. And I think this will be my first exposure to my colleague in India. Hopefully that you will enjoy and take benefit from these presentations. As Robin mentioned, it's about peri-implantitis, but there's something missing. What laser could improve the management of peri-implantitis? So if we start about the peri-implantitis as a growing problem in implant dentistry, this number from United States, every year, and I think 2019, 5 million new implant was implanted for the patients. And we have some interesting information about the percentage of the peri-implantitis. Usually in the research, they give number between 10 to 48%. But if you go for one of the systematic review and they give the percentage of peri-implantitis something around 22%. So in other words, every year we have, just in the United States, we have 1 million case or 1 million implant need treatment for peri-implantitis. And when we are talking about peri-implantitis, we distinguish from peri-implantitis, which is reversible, and sometimes the percentage will reach more than 40%. According to this number, and of course, if we are talking about India, I am not familiar with the number of the implant every year, but something is supposed to be similar. So we have the same risk. Before we promise our patients, so success of the implant more than 90%. But honestly, this is not real number. Maybe the survival of the implant more than 90%. But if we are going for this percentage, and if we call peri-implantitis success, so it will be a big mistake. It will be only survival implant. Just to distinguish in the terminology for peri-implantitis, that means something related to gingivitis, inflammation just only in the soft tissue, and we don't have any kind of the bone destructions around the implant. When we have the bone destructions and exposure of the thread, exposure to the oral cavity or exposure to soft tissue, so in this case, we have the peri-implantitis case. We have some similarity between periodontitis and peri-implantitis, but we have also some differences, very important differences. The first thing, in the peri-implant tissue, we don't have the BDL. And the distance between the base of the sulcus and the bone, it will be very limited. So the access of the bacteria or any inflammation to the bone, it will be more faster than normal periodontal tissues. Something else, the invasion for any lesions in peri-implantitis will be higher than the invasion in any lesions from the periodontal tissue. So in other words, the peri-implantitis is not forgiving case, not like periodontal disease that can live with the patient many years until you have this real bone destructions. While with implant, it will the process more faster. We know for the risk factor for peri-implantitis, something is similar to periodontal disease, like history of periodontitis, patient with active periodontitis, and then the other factor, and something specific for the implant, and always we concentrate in two things, that the residual cements, and this is why always we advise to avoid the cemented crown and going to screw retain. And we have something, the malposition of the implant, especially placing the implant in not correct position with the bone, which lead to bone destruction in the first stage, and later the peri-implantitis action will make this bone destruction faster. Now, first of all, before we go for the management, how to diagnose? We know for periodontal disease, diagnosis depending about many factors, and the periodontal probing is critical issue. As example, if we have pocket more than 3 mil, we can't call it pocket, so it's a pathologic case. More than 5 milli, maybe we need surgery. More than 7 milli, something like this. Actually, in the peri-implantitis, the periodontal probing is important, but it's not critical because we don't have criteria for number. So in some example, we have subcrystal implants. So we expect the starting point, the healthy sulcus will be more than 3-4 millis. So the main issue for if you are using the probing for diagnosis, this is to compare 2 points. The starting point, this is you have to register in the patient file when you install your final restoration. As example, we have the pocket 3 milli or 4 milli, or the sulcus, it's called. If we, in the follow-up after 6 months, 1 year, if you found this number is increasing, so in this case, we can tell that we have some kind of inflammation around the implant. So increasing the probing depth is the main factor if you want to use that one. The bleeding on probing, this is critical. This is tell us that we have inflammation, but until now we don't know how this inflammation reached to the bone or not. So because we have in the bleeding on probing both peri-implantitis and peri-mucositis. And the main diagnostic issue that will be radiographic. This is example for the probing, the challenge in the probing around the implant. because we know we have many factors, shape of the implant, the thread. So the access, sometimes the probing is very difficult. So sometimes if you want to make a probing while you have the crown around the implant, it will not give you real reading, because how you will reach to this over contour of the implant and reach to the contact between the implant and the bone. So always the recommendations, if you want to go the correct probing, in these cases, you have to remove the crowns. And sometimes you need to remove the abutment by itself to reach the implant. And this is the correct probing like this case. For the X-ray, which the value of the X-ray, the first of all, we need to compare 2 points of the X-ray. The first one, when you install the restoration, and then one, the follow-up, then you can see. Because sometimes you choose to insert the implant subcrystal 1, 2 milli. So if you compare this 1, 2 milli, after 1 year, you find this implant now is at the level of the crest. So in the other words, you lose more than 2 milli from around the implant. So this will be something you have to consider. So again, the main things to diagnose the implant, just to know which is the start point for the periodontal implant, then you can compare it by probing and the X-ray. And according to that classification, we will not spend time, but we can know that we have this early, when we have bone loss less than 25% of film implant length, and reaching to advance when the bone loss more than 50%. And of course, to be included with the increasing the periodontal depth or exposure of the implant thread, which is comparing to the recession in the periodontal tissues. There is many tactics how to manage this disease, and I will try to review something before we go to the laser. It will be a very fast review. At the moment, we don't have any standard protocol to manage peri-implantitis treatment. It's exactly like this, like in periodontitis. When you have pocket more than 7 milli, you have to make Whitman flap, and that's and the cleaning debridement. This is standard protocol. While in the peri-implantitis, we have many suggestions, and always I mentioned there's very mass confusions around how to manage peri-implantitis. First, let's compare between two strategies. The first one, they call it non-surgical method. So we will not make any kind of the surgery. We'll try to manage the peri-implantitis without any surgical interactions, like using mechanical instrumentation, similar to scaling, to clean the debris around the implants, use some chemical agent, local antibiotic or a systematic antibiotic, and photodynamic therapy. But according to this very interesting overview about this management, neither treatment to provide conclusive therapeutic effect, because we have, as I mentioned, something different between the implant and the root by itself. So when you make scaling root planing, you can ensure you have this smooth and with the oral patient smooth surface of the roots, and with the patient oral hygiene you can control. While with the implant, we know this irregularity, especially when you have exposure of the thread, irregularity of the titanium surface. This is small gaps. It will be very difficult to clean it. And if you have success as dentist to clean it, it's very difficult for the patient to maintain this cleaning, because he will use all the days using his mouth and the eating, that's one. So we have the plaque accumulations, and the cycle of the disease will start again. For the mechanical instrument, we have some suggestion. Of course, we have to avoid the stainless steels curate. There's some suggestion about using the plastic or titanium scalers. But always we know there's something critical. We need instruments that don't cause any alteration of the surface of the implant. We know all this instrument will make scratching in the implant, remove oxidized titanium layers, and this will compromise the reosteointegration or the healing later. For the air powder abrasives, it's promising, but always for me personally, I have issue with emphysema. If you want to use this one in the closed wound with this high pressure of the air, with the chance the patient to have emphysema, and this is, I think, is something critical. We have to consider it before we recommend this kind of air powder abrasive. Using the chemical agent, of course, it will kill the bacteria, remove the smear layer. But again, the question, how long will last? What, 2 hours, 3 hours? With the first meal, the patient, the accumulation of the food will be around. Photodynamic therapy will go again when discuss the laser. But if you use it, the photodynamic therapy for non-surgical procedures, using some desensitizer like toluidine blue, methylene blue. And we use light resource, LED or laser diode, something like the diode 650, and we expose. So we have the oxygen will cause destruction of the bacteria. Again, the question, how long will last this one? So in this case, because this difficulty of the implant surface, we have some suggestion to make surgical protocol with 2 techniques. The first one, we called it apically positioned flap, to expose the implant, and then to smooth the implant, to remove the titanium, this rough surface of the titanium, and make it smooth. And so this will enable the patient to clean it. I know this is not suggestion for the treatment, especially in the aesthetic zone, whose patient will consider or accept to see this metal part growing from his gum, especially when he has smile line. Maybe in the posterior, when we have long implant, this will be okay, survival solutions. You are using many brush just to exposing, like using ultrasonic, but it's not active because you have the valley area around the implant threads. You will not reach. You are using the peak bears, and we have this kind of 2 bears. This is more efficient in smoothing the implant surface without, because sometimes if you are using the bears, only the bears, like any conventional bears, you remove the thread, and when you have thin implant, you make the implant a risk to implant fracture in the future, and how the implant would withstand with the forces. So the idea, just removing this smear layers, this thin layer of the titanium surface. So always we recommend this round shape bears and or titanium brush. This is give you this appearance like this. But anyhow, we found this is not solution accepted by the patient. So what we suggest now here is the surgical application or the surgical approach, which will enhance the regeneration of the bone around the implant. So always I have this question for any implantologist: how many times you insert the implant, this new implant, maybe in a compromised area, and you keep 2 or 3 threads of your implant exposed, then you place bone graft and GBRs, membranes, and you close the wound and waiting 3, 4, 5 months, 6 months, and go to the second stage. I think any implantologist, they have this scenario in his clinic before, and it's worked. So what the difference here is? If we have implant exposed in the buccal surface as example, or one of the surface, and why we don't apply the GBR in this one? Of course, we have limitation here. This is the main limitation. This implant, the new implant is sterilized implant, while the implant with peri-implantitis is contaminated implant. So we don't expect to success any bone regenerations procedure when we have bacteria in this area. So the challenge here, if we success to sterilize, let's to be more accurate, to decontaminate the implant surface, to remove the bacteria from the implant surface. So in this case, without changing or alteration the implant or the titanium surface, so in this case, we will be with the same scenario when you insert a new implant, and maybe with the same success rates. So let's discuss this issue. So the main thing is the peri-implantitis, the periodontal pathogenic bacteria. And here is the logics coming from the laser, why you are using lasers. As I mentioned, when you are using mechanical instrument to clean the implant surface, you cause damage to the titanium surface, and this will compromise the bone regeneration. When you are using chemical agent, you have some toxic effect, especially often the cell, like the osteoblast or the cell that you need for the healing. When you are using abrasive powders, this powder maybe will stuck between the gaps. So when you place your bone graft, this powder will prevent the reosteointegrations or reintegration or regeneration, let's call it, because we don't know it's reosteointegration or osteointegration. While when you are using laser, the laser is light. The light will interact with the bacteria, will remove the smear layers, keep the implant surface sterilized. Then you can apply your bone graft and all the surgical, the GBR procedures. But here we have to distinguish between lasers, because some laser we can use it, some laser we can't use it. Let's concentrate in two kinds of the laser. Maybe the main laser that we have in dental markets, the diode groups, which absorb by hemoglobin and melanins. And we have the Erbium group, which absorb mainly by the water. So we will discuss now when we use this one or when you use this one and what the alterations. Here's the coefficient absorptions, this wavelength with hemoglobin, with melanin, with water, and hydroxyapatite. But now with the peri-implantitis, we have something different now, something additional. We are dealing, of course, with the bone and the blood, but always we are dealing with the titanium. And I mentioned, we have two conditions to success of this procedure. The first one, decontamination of the implant surface, and the second one, no alteration, no change on the morphology of the implant or this and the implant surface and the titanium layers. So when we go for the wavelength and how this wavelength interacts with the titanium, we find this some kind of far infrared like CO2. It's very limited absorption in titanium, which is good here. We don't need this absorption, because absorptions mean overheating the implant. Overheating the implant would be overheating surrounding the bone and the chance of the bone necrosis. While we find some wavelength, like example, the blue laser 450 is high absorbed by titanium. So in this case, it will be high risky. In diag, also it's high absorbed, but will be with more energy, and this will cause some kind of the melting of the implant surface. So we don't expect the success of the procedure. The diode group, most of you, they will ask me about diode because most of the doctors, they have diode. The diode we will discuss later. But the concept mainly, we needed decontamination of the implant surface and killing the bacteria, and of course, the degranulation of the tissue around the implant and remove all this inflamed area. We know that mainly the near-infrared laser like diode in diag is very active in management of the bacteria around the periodontal disease. And the good news, usually the same bacteria, we have it around the tooth, we have the same in the implant. And when we are talking about peri-implantitis, mainly the pigmented bacteria like Porphyrias gingivalis or Brevetella intermedia. And this bacteria is like the near-infrared. It is a very to absorb this kind of wavelength. So it's very easy to kill this bacteria with low doses from this lasers. First, in diag. In diag, of course, maybe many of the laser users, they agree me, it's contraindicated around the implant surface because it causes melting and causing craters in the implant. Actually, the lab using the Nd:YAG laser to weld the titanium. So we know this one can weld the titanium, so weld the implant surface. I call this melting surface. So we don't expect the success for any treatment, and of course, the high risk of the temperature increase. Now for the diode. the diode is critical. Always I give this example. The diode, the toxic dose is very nearby from the therapy dose. You can expose, you can irradiate the implant surface with the diodes, but you need the correct parameters. But if you exceed this parameter a little, you will have chance to increase the temperature. We know for the bone, it's accepted only increasing the temperature until up to 47 centigrade. So the threshold of the damage of the bone, it will be 10 degrees. For any procedure, we will do it with the bone. If we increase the temperature more than 10 degrees from the baseline temperature, you will have chance, will compromise the bone vitalities. In this research, very nice research, you compare 810 and 980 nanometer diodes with 2 watts. And he found after 14 seconds or 12 seconds that temperature increased more than 10 centigrade. So in other words, you can use laser according to this setting with continuous 2 watt, but not more than 10 seconds. After 10 seconds, you overheat the implant surface, and at the same time, you overheat the surrounding tissue. But the good thing about the diode is not like the Nd:YAG. We don't have any change in the titanium coating, so it's good. So if you can use it in the correct parameters, this is the main challenge. This is another research, interesting one, comparing different kind of the implants, zirconia or titanium surface or selective, and he using 20 seconds for 1 watt. Now less power, but more time. And was impulsing mode with duty cycle 50%. And he found the increasing of the temperature for all these kind, it was more than 10 centigrade. So 20 seconds is more than enough. It will be, you will cause the damage. So always try to control how much the temperature will raise after irradiation with laser. So this is the main challenge about the using of the diode. Because as I mentioned, when you choose your laser, suppose you have to choose the correct wavelength. The second thing, how the laser will interact. And of course, the laser parameter, you are using continuous or pulsing, you're using with the pulse duration, with the power energy, with the power, with the energy density. All this is a factor you have to consider. And something very important, what the kind of the implant surface. This is another variations, because we know, as in the last research, like selective interact with the laser different from the, as example, the plasma implant or with the tuned implants surface. So again, sometimes this is very important to consider it. And especially in the research, when you read research about peri-implantitis, if the researcher didn't mention what the kind of the implant surface, we can't rely on this research because it will be different. 10 degrees in some implant, you need to reach it after 10 seconds. To reach 10 degrees in other kind of the implant surface, maybe you need 20 seconds. So this is main issues. And who asked me about always the mechanical accurate, tell me this is gap less than 500 micron. How you will clean it with the mechanical accurate or the ultrasonic tips? You don't have instrument less than 5 micron to insert and go inside ears and to make the cleaning. Here we are comparing with Erbium with different kind of implant surface, and we found here's the threshold of the melting of the implant. Like in the TPS implant, when you reach only something around 9 joules centimeter square, you cause melting. While with the smooth titanium surface, you reach 28. So this is the main variation that we have to consider. Let's go clinically now. This is maybe the first case I see it in the literature for my mentor, Georgia Romanos. I think he published in 1997. About using the, here's this article 2008, but he has publishing something in 1997 about using the CO2 for decontamination in implant and then using the GBR procedures. Now let's go for the main part of its presentations. Yes, we are on the time. Using the Erbium. The Erbium now, this is the much promising wavelength that we use it in the implant for many factors. The first, the Erbium is absorbed by the water. And we have the water everywhere. We have it in the soft tissue, we have it in the bone, and we have it in the bacteria under the plaque. More than 75% of the plaque is water. So it can cover all this area. You can degranulate the tissue, you can clean the bone, make decortication for the bone to invoke the bleeding, and at the same time, decontaminate the implant surface. We have minimal thermal damage, less than according which kind of erbium or 2940 or to 780, something between 5 to 15 micrometers, only the thermal damage. And the main things about the Erbium, the relaxation time. We don't have increasing of the temperatures of the implant. So in some research, I don't mention here, the increasing of the temperature with the Erbium less than 3 degrees when you are using 200 millijoule under the irrigation. So it's very safe wavelength in regard the overheating. But of course, if you are using the correct parameter, short pulse duration, this frequency, high water irrigations, this is very critical. Something additional, Erbium work in two things. The first, direct beam of the implant when we meet the bacteria as in the surface, 10 or 15 micron will kill this bacteria. Because the bacteria, we have water, the water will absorb by Erbium, we do vaporization, and we have this bactericidal effect. The second thing is very interesting about the Erbium. This is indirect effect. We call it the shock wave. The shock wave, like this, the shock wave will go to the implant surface, will clean it completely, remove any smear layer. This is something extra. We have the direct effect and indirect effect. This is clinically, this is kind of the shock wave, how it works with the water. We have this bubble. Actually, if you heard the voice, like call it. And this is very strong, especially when you are working in a small area. And as I mentioned, depending about your pulse duration. You need very short pulse duration to achieve this shock wave effect. So now clinically, when I start dealing with peri-implantitis, always I have doubt about the research. Always I try to see something in my eyes. In this example, I choose 3 kinds of implant with selective surface, and we create something similar for accumulation of the plaque and calculus around an implant. And I watch different settings. Here I'm using laser for biolaser, erbium, chromium, YSGG. And we are comparing what the effect. This is like example, the company settings. In this example, we increase the power, the average power. Now it's more effective, but you notice every time we touch the implant, we have melting. Now increase it 3.5, but always we try to, without touching the implant with non-contact, yes, we are more effective in the cleaning. So clinically, this is what you need. If you are using the microscope like one, you need to clean without causing changing of the color of the titanium, or you have scratching like this. So the main things about using the correct setting, because this setting do nothing. So, and the same thing, we don't have high power that will cause the damage of the implant surface. What about water irrigation and the mode of the application, contact or non-contact? Of course, with the implant, avoid the non-contact. If you here is when I make the contact, I cause the damage. And this is that something is very important when you compare between the flapless and the flap in management of peri-implantitis. My issue with the flapless always how you will avoid touching of your tip to implant surface, especially when we have some kind of implant, we have aggressive threads. So every time when you go in flapless, you have chance to this tip will touch the implant. When you touch the implant, you have caused this damage. Of course, the water irrigation is very important, how to use it. You have to increase it to keep the cooling, because when you don't have water, you have dehydration of the implant and chance of the overheating. And this is one of the setting of one research using 0 water with 6 watt. Of course, with this one will cause melting and the implant surface. So it's depending about the parameters, how you are using. Don't read just paper and tell me it's called Erbium cause the melting. Cause melting, which setting they are using, which the applications, with the implant surface, and all these parameters. Clinically, we have case like this. Look clearly that patient have issue with that issue. And I remember when I make the probing for the patient here, I found the probing was 2 milli, 3 milli, not more, with the crown. And you can find the oral hygiene of the patient. I take the photo exactly when the patient visit the clinic. It's not correct, but we don't always complain from the patient oral hygiene. Always we have another factors that, like example, we see this implant, the malposition of the implant. So we remove the crown, and now we found, yeah, we have real problem. We have pocket tears, more than 5 millis, bleeding on the cupping, and I'm showing how the procedure. Can we access the implant without removal of the crown? From my experience, it's very difficult, and you can't ensure to reaching to all the implant surface. So usually the best solution to make this cleaning, you have to remove the crown and remove the abutment. We are using now the erbium laser. As I mentioned, it's absorbed by soft tissue, so I can remove all these granule tissues around the implant. It will be very safe procedure, because if I am using any mechanical instrument, always you have chance to create some scratch of the implant surface. As you see here, there are some scratch already there. I don't know where it's come from. But as I mentioned, did you expect to see this bone defect before raising the flap, especially of the buccal bone? We know that malposition of the implant and place it little buccal is, maybe this was the main factors that lead to bone destruction, but later we have peri-implantitis developing around the implant. So we take our time to clean all the implants, the granule tissue, until we reach to the clean bone surface. Now make the video a little faster. After the cleaning, and this is the real time work. Now I'm using my laser, non-contact with the implant, and I will pass it all the implant surface. Now with the laser irradiation, we'll remove all the smear layer, we remove and kill all the bacteria around the implant, and I will just switch. This is the music, not the real voice. So that's point. Just I'm showing without switching of the light. This is the light, how it interacts. Now, if you can ask me here, doctor, I don't have erbium. What I can do, only I have diode. Yes, and this is step. After your granule tissue, you open the flap. You can use your diode like this, but don't spend more than 10 seconds for each application. Try to make it a large spot size, and you need to calculate your energy density exactly according to the tip you are using. You are using 400 tip, what the divergence you have it. If you are using glass rod, what the power you are needed. You need more power because you have more diameters. And in this step, if you are using the diodes, you have to cover all the surface. We have webinar before 3 days, and George Romans have many research about using diode with implants, especially the temperature change. And his recommendation usually use something around 1 watt powers for 10 seconds, then stop at least for 5 seconds, then again. Okay. Which most important, maybe it's more something more safe, the photodynamic therapy. And this stage, when you clean everything of the implant, we are removing the smear layers here and everything, then you can place polyvinyl blue, 20 micrograms, the weights, and you place the palladium blue for 30 seconds, then you wash it out. After that, you apply your diode laser in very low power, something around 100 milliwatt. This 100 milliwatt will not cause overheating of the implant, will activate the collagen pool absorbed by the bacteria and will kill this bacteria effect. This will be more safe. This is when the now, yes, I'm using photodynamic, but not for non-surgical. I'm using for photodynamic, for surgical, because I need to sterilize this surface just only for this 10 minutes, 5 minutes until my bone graft material arrive. So when bone graft, I place it, I'm sure I don't overheat of the bone. I have the blood supply, something I don't mention. Always when I finish the cleaning, I'm using the Erbium. If you can see here clearly, I'm using the Erbium to make small hole in the bone to invoke the bleeding. I need the normal blood to come. This will help with the regenerations. After that, you're placing the bone graft. Like in this case, when you have implant in malposition buccally, we need this some kind of the support. The membrane by itself, the collagen membrane will not give me the support. So in this case, I'm using the titanium mesh to give me this kind of mechanical support to my graft. Then you can make the cleaning and exposing. How you want to make it submerge or merge depending about the soft tissue you have it. But always you have to control good enclosures. I'm using the laser after the closure. I'm using the diode by itself to give me this seal effect, if you can see it here. But of course, in coagulation setting, not high power. Of course, if you are using any additional material, this is the kind of the bleeding you needed before you place your bone graft. And with all you are using the erbium, because the erbium can interact with the bone, but of course, with different setting. This is the case. The patient, they have a story with this patient. You worked more than 3 years with them, or 2 years. The patient just visit our clinic with this is his temporization, and he left the clinic. And he came just last month or 2 months ago. He come for something different. He want to make crown lengthening in the posterior. It was referred from my colleague, Dr. Muhammad. And the first thing I want to notice what's happening is, this is the dream for any periodontist. When you probe around the implant and you have the white patches. This white patch tell you that you don't have now good attachments. And remember, this is temporization still. And this is 2 years temporization. So of course, if we have the final later, that would be much, much better. But we can see the improvement in the papilla region, improvement in the soft tissue, improvement in the quality of the attached gingiva, and of course, is much important thing, the improvement. Here's, I try to push my, because after 2 years, it's okay. I try to push my probe. Usually you prefer the implant use plastic prep. I try to push it so I invoke the bleeding, but I still, when I push, this is the maximum, less than 2 mil, the insertion of the propping. Another case, we make the video very fast, 15 minutes still. So this is a more challenging case. Actually, our plan to remove this implant, they have fracture of screw here, the doctor inserted with temporary filling, something disasters anyhow. So when you plan this procedure, when I open, I found this kind of wood. Now I am testing the apartment, nothing damage inside the platform. I success to remove the fracture screw from the implant. Now I begin to think, if I want to remove this implant, how much the bone I have to remove, what kind the procedure I suggest. I need to place bone graft, mostly block bone graft. I will keep it 6 months, then reinserting of the implant, and what's the chance of the success. Here's I discuss with the patient. Let's try something. I will try to clean your implant, and I will place bone graft and try to survive these 2 implants, because I need this bone. This bone is very critical. If I'm using my Refine, I remove this implant, I remove this bone. Very difficult to later to build this bone vertically. We know the implant is very near each other, so when you are reviewing with the tooth, all this bone will be disaster like this. So what we will do, we make the cleaning of the same issue, the cleaning of the implant surface, cleaning the decontamination. We are using now, if you can see, I am using decortication of the bone. I still working like hole inside the bone until I want to reach to the blooding, and now I'm checking just only because we have fracture screw here. Just I want to check that I can install everything and can clean. This is the bleeding I needed. I clean all the implant. I remove all the bone from here. I place my bone graft materials, and again because I am not big fan for the titanium, but sometimes when you don't have this kind of the support when the implant with this exposure, especially in this area, is very easy to patient to make a pressure. So the immobilization of the graft is very critical in the success. So in this case, I am going only for the titanium mesh, which is, I know it's very sensitive, but you can do it. With the improvement with the laser advance, like we have this nice tips. You can see it. Sorry. Okay, sounds very high. Just click the sound. Yeah, cool. So we are using the side firing tip. The good thing about the tip, you can insert it and we give you the laser in 90 degrees. So now I clean under the thread. I can clean in the valley area, which is very critical. Who want to hear this voice, just run the video again. This bonding voice, this is where is your shock wave you are doing now, how the laser absorbed by the water. And you can watch the cleaning of the implant. Actually, this step is more efficient than I showed before, the radial one, but this is new, just I think they're launching in the market in maybe in 2018 or 17, I think 2018. So this is very nice research from Romanos again. He's maybe a good father of the research of laser and implantology. He's tried something here. He bring a new implant, different kind of the implant machine, the hydroxyapatite, sandblasting or TBS. And he irradiate the new implant. And he irradiate this implant with different kind of laser, Erbium chromium or CO2 or non-laser. Then he insert the implant in the bone and he checked what the chance of the osseointegration. And he found no difference in the rate of osseointegration with implant with laser irradiated or non-laser irradiated. So in other words, laser will not cause any damage, these two lasers, because for the implant surface, it will not change with the oxidizing titanium layers, so will not compromise or change the osseointegration ability around this implant. So we can use it very safely. And this is very good review. And remember, this is published in high impact factor journal of periodontology. This laser disinfection is effective adjunctive treatment to the bone augmentation for peri-implantitis. And the conclusion, after 5 years post-operative, laser give you the best chance to success of this procedure because you can ensure the decontamination of the implant without changing of the implant surface of the titanium, which is the two main factors. It's a very interesting paper. You just try to take screenshot and read it because it's review more than all this kind of research from Romanos, Debbie, and all these groups. Now, for this last case, I want to mention, this is something, now this is the age of this case, more than 7 years or more, that is what started in 2010. The procedure, again, malposition of the implant, this is what we notice, especially in the upper teeth. The malposition of the implant, place it in the buccal surface, you have the bone destruction, okay, which is mechanical bone destruction, maybe the necrosis around when you make pressure on the bone in this area, or because you have very limited area, because all of you know the suggestion to keep at least 2 milli from the bone around the implant. But later what happened, we have developing of the peri-implantitis. So I think malposition of the implant, one the main reason actually is more, this is just for me and my observations. I noticed that the malposition of the implant causes more chance for peri-implantitis than the residual cement that will make it 100%. for the peri-implantitis. Again, this is another kind of erbium. It was erbium 2940, cleaning of the implant. The same issue, placing the bone grafting material, closure here. This is using membrane and tags. This is after 4 months when the patient come to the clinic, we exposed and we found this nice healing. So again, it's like a new implant. Just if you success to clean this implant. And of course, there's something I forget to mention, how many wall you have. You know, with success with any bone graft material, depending the topography of the defects. If you have 3 wall, you have more chance to success when you have 2 wall. And when you have horizontal, it will be more difficult to achieve the regenerations. You can see here the success around the implant and the bone. Of course, we make some connective tissue graft with stiblasti. The laser, you can use this one. You make the epithelialization with laser. The epithelialization give you a chance to create connective attachment more than epithelial attachment. So this will help you. This is the healing after the second stage. This is the patient. And this is the probing of the patient after 20 months, almost 2 years. Anyhow, this patient until now visits my clinic, almost around 9 years, and you have stabilization. And again, this is when you have the probing and you have this white patch, still you have good attachment around the implant. So in other words, we can save the implant. Last slide, always I keep it on my presentation. This is my case. I remember we placed the implant for the patient upper and lower in 2009. The patient, the follow-up, she traveled, she came to my clinic in 2013 just to follow up. And she told me, well, just here I discovered to see something like this is black issue. Okay, I told you this is serious issue. Of course, we have 1 thread here, 1 or 2 thread here. We don't have an issue here, but I told her, this is, we can't predict this bridge will live forever. For upper, okay, everything okay, is it good? But now for lower, I thought we have to make something. And my suggestion for you, I have, this is screw retained bridge. I will remove the bridge. We'll make grafting, the GBR and everything I mentioned with the laser, and we close because now I need something support from the buccal. And we make it as submerged implant. We keep it clean for 3 month healing. Then we will come and we will place the same bridge. No need to pay more. Actually, the patient take the appointment. This is exactly the story. I asked the reception to keep for your appointment at least 3 hours because I need to take more time in the working. I'm working in 3 implants. And the only things that's happened, that's the patient, she came, but she came late 3 years, not 3 days. And this is the position after 3 years. So in this case, I told her we can do nothing here. Of course, the implant is still stable. Sometimes you have only 2-3 million implant bone and the bone still stable. You don't have any mobility. But I told her, here's, forget what I suggested before. Now I have don't have any wall that support my bone grafts. I don't expect any success for case like this. The building the bone vertically, 7 milli, 8 milli around this implant. I told her the only suggestion I have to you now, we need to remove this implant, grafting this area, and we make the implant again, and you have to pay all these things, the implant and the prosthetic and everything. So the message here is when you see, especially for any implantologist, when you see 1 thread on here, don't expect that will resolve. This rough surface will attract the bacteria and you will have this cycle of disease. Believe me, I try many things in my practice, the cleaning, the ultrasonic, using photodynamic, and that's one. Okay, patient improve the perimucositis for a while. You can't ask the patient to come every week to clean this implant all his life. Because the question, how can you clean this one? Okay, maybe other suggestion now to make it apically position flap and make smoothing of the implant surface, as I mentioned. but it will be not the best solution for the patient. So the take-home message from this presentation: in case of bone loss around any implant related to peri-implantitis, where the implant is still stable, of course, and the bone loss is not too severe, and we have some wall that can improve the success of your GBR. So the the laser is work, of course, but as surgical. Lasering will be co-adjunctive, just will help you to decontaminate the implant surface without changing of this titanium until you have your GBR procedure. In other words, you are using the laser to sterilize your implant to keep it as the manufacturer give it to you. Something similar like this. And erbium laser is the best wavelength for me to deal with this solution, because we have less thermal damage and we can deal with this all composition without any collateral damage to the bone, the soft tissue, and the titanium surface by itself. And always for all my presentation, I finish with Ernest Hemingway: the best way to find out if you can trust somebody is to trust it. So the people who always against the laser, please don't judge it only when you are reading the paper. You have to work it in your hands and you have to watch the result. I am periodontist before I am laser dentist. So I can tell you, yeah, laser changing something in my practice in periodontology and implantology and make it much better. But I know for the laser, you need the knowledge and you need the experience. And of course, we have many misleading information here's and here's. So you have to control everything and to improve. And this is the message or the mission of American Academy of Laser Dentistry. We are bringing the laser dentistry to the clinical levels, not only the physical level on the lab. We lift the lab. Of course, we take all the science from the lab, but now we are going for clinical evaluation to see what the result. We have this program for international fellowship, 17 speakers, 17 clinical speakers, and of course, educator and the university from all around the world, from all the 4 continents. The program is building on, because with the COVID issue now, we changed the program to make it part of its online for 80 hours, 20 days, 4 days for each per month, and we finished it in 5 months. Then we have the practical, because we believe at the end, when you have this knowledge now in your head, now you have to practice in your hand, and the practicing, not only it will be in the sheep head or in the animals or something, we're practicing on the patients or on our real patient, just to show the result. Again, it's clinical driven program. We are starting in 2017. We have multi-batches in Dubai, in Qatar, in Algeria, and Poland. And this will be the first batch with online. It will be good exposure, especially for our friends, because we received many requests from India. And I remember many of my colleagues from India came and joined this program, but they have to travel to Dubai every month, 2 days, 2 days, 2 days. Now with the online, we have the opportunity to finish all this dedication program or dedication part by online. We keep only one visit, 5 to 6 days to finish the practical issue. And hopefully you enjoy the presentation. And I think I am done my admin. I have the time. It's 1 hour exactly.
Thank you for the presentation, sir. It was indeed a lovely presentation. Friends, we have the master himself, person who's well-versed with this wonderful concept. If you have any questions related to today's topic, please feel free to post them in the Q&A box. We would be covering them shortly. Dr. Walid, I request you to stop your screen share for a moment.
Okay.
Friends, I welcome you on behalf of DentistChannel.Online for this presentation. I'm sure the presentation was a fun learning session. If you like the presentation, you can attend the other presentations that we've lined up specially for you. The next presentation would be on the 20th of June. I'm going to give you the details very shortly. And that is us, DentistChannel.Online, a dental media company, thanking you for being a part of this presentation. Ladies and gentlemen, it's my pleasure and my privilege to welcome you as our esteemed participants for the world's first virtual dental implant expo that is going to take place from the 17th to the 22nd of August 2020. This expo is packed with a lot of scientific sessions as well as masterclass sessions. We have stalwarts and master implantologists from all across the globe going to come on our platform and going to speak during the expo. Like I mentioned, the expo is going to take place from the 17th to the 22nd of the August. Registration for the expo is absolutely free of cost, and you can register yourself as a participant for any of the sessions that you like of your choice on www.dentistchannel.online/implant expo. I repeat, www.dentistchannel.online/implant expo. Repeat, the registration is absolutely free of cost and you can benefit from the number of presentations that we've lined up specially for you. Dr. Walid has already mentioned about the program. This is the International Fellowship of Academy of Laser Dentistry. For the ones who wish to know more about the course, can get in touch with us, DentistChannel.Online. We would love to give you more information on the course. Like I mentioned, you can message us on the below mentioned WhatsApp number. That's the WhatsApp number. If you wish to register for the International Fellowship of Academy of Laser Dentistry, like doctors already mentioned, it will be an online session along with the hands-on or the actual workshop session, which would be taking place for about 5 to 6 days. And that's the complete flow of the plan. And you can get in touch with us to know more and to know more in detail. This is about the next session. The next webinar would be on the topic growth factors, evolution of applications in implant practice. We have a speaker, Dr. Ahmed Osman, who would be delivering this scientific presentation on this Sunday, the 28th of June at 11 a.m. Indian Standard Time and 9:30 a.m. UAE time. If you would like to register for this presentation, please feel free to register by getting in touch with us on the WhatsApp number that you are always in touch with us. Thank you, ladies and gentlemen. And now we come to the very important topic, that is the live question and answer. Start with the first question from Dr. Ankur. Which laser is used in both soft and hard tissue management and which is safe?
Okay, do you hear me?
Yes, sir.
Yeah, as I mentioned, the Erbium group, you already mentioned Erbium 2940 and 2780. This is the only one that we are using. And of course, we have another wavelength. We have it in the United States, only it's CO2 9300 nanometers. Also, we can use it in both in soft and hard tissues. The others wave like diodes or NTAG, of course, we can't use it with the bone. We can't use it with hard tissues.
Thank you, sir. Next question from Dr. Bucket. In case of using diode lasers, 10 seconds with 5 seconds break as suggested, what is the recommended wavelength and watts?
Okay. Now recommended wavelength, the wavelength that you have it as diode. Usually you have 980, 940, 810s. And of course we have the new one, the 470 or 450, the blue. Depending about the wavelength that you have, you can adjust the setting. But we know like the blue one, 450 and 810, we're having more increase in the temperature of the implant. So if you have the chance, because sometimes you are device with multi-wavelength, so choose 980 or 940. Now the parameter, the watt is depending not to using 1 watt or 2 watt or 3 watt. This is not correct to give the parameters. Giving the parameter depending about something called the power density. How much the power and the power, the percentage of the power and the surface. So it's depending about the tip you are using. As example, if you are using 400 tip and far away from the implant 5 milli, you have this same divergence, so you have a spot size. Then you, according to this spot size, you can calculate your power density. Sometimes if you are using the glass rods with more large diameters, like example 8 milli, so the spot size will be larger, so you need to increase the power. So depending about what you have in your laser device. So always your calculation depending about your power density. But Now let's go a little clinically. Look now like physics talk. Of course, the physics always correct, and we need it. But the main issue here is you can make it in your clinic, very experimental and very easy to do it. And this is what I did in my practice. Bring one of the implant, one your implant, failed implant, just outside the patient mouth. And you can use thermostat. You have now the infrared one. I have one. You can calculate up to 100 degrees and it irradiate your laser to the implant surface with different setting. And then calculate the temperature. And this will tell you exactly what you need inside the patient mouth. Of course, inside the patient mouth will be more easier because you have more scattering for the laser by itself, and you have the cooling mechanism come from the blood supplies, from the suction, from that one. But let's take that example. From my experience, if you are using 980, you can use it 1 watt. This is my experience. You are using 400 tip. 400 tip, 5 milli distance from the implant surface. And you are using 1 watt. You make it in pulsing, but with a long pulse 100 millisecond. And the off time will be 100 milliseconds. So the duty cycle 50%. And with this one, will give you 5 hertz. And you irradiate the implant up to 10 seconds only. Then relax, 5 seconds. Then I again irradiate the other area up to 10 seconds. When you are using the glass rods, you need to increase the power and increase the power more than 4 watts. And this is depending your device can deliver this watt or not. But with the glass rod, the good idea that you are covering larger surface of the implant. So you don't need multi-application 1, 2, 3, 4, 5 for the small tip. Now with large tip, you can apply it just in 1 or 2 application. So again, the main issue before you place the setting, what the kind of the tip, what the distance. What's something you have to avoid? Avoid touching the implant with the tip. According to Giorgio Romano's new research, it's not published, avoid the initiating of the tip because he notes when you initiate the tip nearby the implant, it has more overheating. Okay. And keep something very interesting that Romanos he mentioned last his webinar. When you have splitting implant, you have a bridge. When you irradiate one implant, the temperature will move and will conducting and reaching to the other implant. So always calculate your time. From my clinical experience, no need what they mentioned in the paper. For some paper, they are using 3 watt or 4 watt, and 2 watt is too much. So don't exceed more than 1. And remember, your target here is kind of the bacteria is high pigmented bacteria. And high pigmented bacteria, it need less energy density to reach the threshold of the damage. So we don't need this high power, we irradiate. But the most safe things, if you have photodynamics, just to bring your toluidine blue and activate it by the laser. And now you are very safe using killing of the bacteria without have any chance for overheating the implant. Sometimes that's what's happening in real life. You feel boring when you irradiate 10 seconds, then you forget to calculating or counting, and you don't spend, and this overheating. And the problem that you don't see the overheating. 47 degrees, you don't see it, okay? But the bone is very sensitive for that one.
Thank you, sir. Next question. Please explain the clinical difference between periodontitis and peri-implantitis.
Yes, as I mentioned, the main difference come from the anatomy. What the difference between the implant and the roots? With implant, we have tissue, we have the gum, the gingiva, and we have the bone. But with the implant, with the tooth, we have the BDL. With implant, we have very, very thin or limited attachments. All the attachments, epithelial attachments, and very short. While we know with the supracrystal attachment in the normal periodontal tissue, it's something which we called it before biologic weight is 2 milli. We don't have this 2 milli in the implant as attachment. Mostly it's epithelial attachment. And we know the epithelial attachment is weaker. And something in the implant, again, in the anatomy. At the base of the sulcus, the thickness of the epithelium is very limited. Sometimes this is than 50 micron, and sometimes we have ulcerations. So the connective is exposed, or the tissue, connective tissue exposed to the sulcus. This is, in other words, we don't have good barrier to prevent the bacteria from going inside, while we have this kind of the barrier, the attachment, and in the normal teeth. And this way, the disease will be more aggressive, and it's very easy. And as I mentioned, the bone is very near to the attachment area, so the bone will be affected very fast. As example, if you need to get periodontal disease 3-4 years, with the rate of the implant will be faster. Maybe 1 year we have the same destruction that we have 4 years in normal teeth. Just as number, just for the explanations. This is the main issue about that. Now, when you want to deal with that one, as I mentioned, the main issue with the implant is bone contact. With tooth, when you make periodontal treatment, the main issue for you, the BDL and the attachment. It's more than the bone. Sometimes in the recession cases, we have attachment, long attachments, bone destruction, but the tissue there's. With implant, no, the issue is the bone. If we don't have the bone will not support the soft tissue. So any management for peri-implantitis, when you have bone destruction, I don't trust with the non-surgical. So you have to rebuild the bone around the implant, because we can't accept that the implant to be exposed, while we can accept the root is exposed to oral cavity, because it's very easy to clean the root and to make smoothing and the oral hygiene like any periodontal treatments. While with the implant, this rough surface, regardless what's the patient motivation and what's the patient oral hygiene, no one can clean this micro gap in the implant surface. So the ideal, the treatment, it will be to rebuilding the bone around the implant. Always for the terminology, after the regeneration or the GBR procedure around the implant, we can't tell this is osseointegration. Some terminology call it re-osseointegration. Anyhow, this is not big issue for me. I need the bone to support and to protect the implant, regardless it's osseointegrated or not osseointegrated in the implant surface, because you need to take sample and you cut it and the patient and to know that you have real osseointegration or not.
Thank you, sir. Next question from Dr. Sara Abbas. In case of dehiscence defect implant, is it enough to just use bone graft, or it should be used with a barrier membrane? What is the success rate in both the cases?
It depends again. We know if you are using the bone graft alone, you have to ask yourself, is the bone graft will be stable or not? This is one. And what's about the soft tissue? When you close over that one and the soft tissue will go inside this bone material, can interact with the healing process or no? For me, any bone graft material, especially in that one, we know it's actually, we call it filler material. We are filling the gaps here, but we need something to protect and keep this gap. So we are using the membrane. The membrane gives us main thing to keep the gap and to prevent the mobilization of the bone graft material. So I think when you don't use the membrane, regardless what kind of the membrane, maybe you will compromise your healing. I know for some school now, they are going for something, just insert the membrane and place the bone graft. If you have 3-4 wall, it's okay. So you can ensure that your bone graft material will stay there. But if you don't have support, especially when you have buccal dimension, you don't have the buccal bone to support your bone. So you need something to give you this support. So immobilization of the bone graft is very critical in the success rate. So always my recommendation to use, of course, the membrane. Some suggestion, I think for your next webinar with my friend, Dr. Ahmad, he will mention that using the BRF material as membrane, of course, but the same again. You need something to stabilize your bone graft material and to isolate it from decontamination.
Thank you, sir. Well, with that, we come to the end of the lovely presentation. On behalf of Team DentistChannel.Online, I would like to thank you for the wonderful presentation and for answering to the questions in detail. I'm sure the people who have asked the questions, they've loved your answers, and the answers were crisp, clear, precise, and covered in length. Thank you very much for your lovely time and for your presence.
Thank you, Rupen. Thank you, Dentistry Online, and hopefully we'll meet soon. Thank you very
Thank you,
much
sir.
for
We
the
hope to
kind
meet soon.
invitation. Thank you
Thank
very
you, sir.
much. Yeah.
Thank you,
Goodbye.
ladies and gentlemen. May you all have a good day.